Please welcome Associate Professor Albert Romeo Garcia.
Thanks very much, and thank you all for having me. Thanks for your attention. It's been a long day, I know, so hopefully we'll end it on a high note here. Been a lot of great talks, though, and really want to thank Mind Foundation and the organizers and Charles University also for having us here today. I'm going to talk about, and this is actually with kind of in line with the theme of metamorphosis in psychedelic science, new directions in psychedelic therapy, and particularly, we've been working for a long time on psilocybin, ayahuasca, LSD, and other psychedelics for mental health conditions, which I think is great, and there's a lot more work to be done. But the more we learn about these drugs, we understand that they have this biological activity, and people have talked about things in terms of their brain effects, potentially microbiome effects, anti-inflammatory effects. So I'll talk a little bit about that stuff today, which I think can also be relevant for treating other types of what we might consider more physical or physiological-based illnesses. And so this is a new line of work that I think is developing now rapidly, and we'll probably see a lot more of in the coming decade. Sorry. A couple of disclosures. I'm a paid advisor to some companies that are developing psychedelic medicines, and I've also received research funding from the U.S. federal government, Department of Defense, National Institutes of Health, and also a number of companies and nonprofit organizations. So thankfully, since we have a very well-educated crowd here, and the presenters before me did a wonderful job, we'll be able to breeze through a lot of this introductory material, but I'll really be focusing on these classic psychedelics today. I won't be talking much about ketamine or MDMA or some of these other really interesting novel psychoactives. But these classic psychedelics, we think this serotonin 2A receptor mechanism is one of the main driving forces behind the way that they work. And what's quite interesting is that many of these are just found in nature. So psilocin comes from mushrooms. Dimethyltryptamine is found in many different kinds of plants and animals. We found mescaline in different types of cacti. And, LSD, of course, being semi-synthetic and synthesized in a laboratory. But all of these are very similar to our, one of our major neurotransmitters, serotonin, which, again, we think is how some of these drugs are exerting these long-lasting, powerful effects. And, of course, psilocybin is really something that I've been spending a lot of time studying over the last 13 years at Hopkins. And it's found in about 200 different species of mushrooms. So I think it's a really interesting alkaloid that is naturally occurring. Just like a coffee bean produces caffeine, which we use for stimulant properties, these mushrooms create the alkaloid psilocybin. And just as we were hearing earlier, there's a very long history of use among indigenous cultures. These are some mushroom stones in the middle of the slide here from Guatemala. They're about 3,000 years old, but they are clearly showing that these had some religious or spiritual importance to these cultures for them to be making these types of icons. And actually, interestingly, one of the first written records we have is from about the 1520s from this fellow here. They actually often call him the father of ethnography. His name is Bernardino de Sahagún. He was a Franciscan friar who wrote this really extensive documentation of the lives of people in Central America when he encountered them, and it was called the Florentine Codex. But what he found, one of the things he found was that they were using these mushrooms, particularly the Aztec people, they called them Teonanacatl, which roughly translates to divine flesh or God's flesh. And what he said was they would take these mushrooms, they seemed to be intoxicating, and they would cause visions and provoke sensuousness. They would be used for healing purposes in nighttime ceremonies where people would dance, sing, and weep, and sit in a meditative mood. And once the effects wore off, people would talk about the visions they'd seen. So almost sounds like some sort of religious spiritual use, or maybe even very early psychedelic therapy, if you want to think of it that way. But this is obviously going back to the earliest written records we have in Western history. Obviously, they were doing this probably long before. And just to put this in context, We didn't know about psilocybin really in Western science until 1955, and that just happened to be the case, thanks to the lady you see here, Maria Sabina, who was a Mazatec healer in Huautla, Mexico. And actually, there's a great photo there of Gordon Wasson when he was first given the psilocybin-containing mushrooms. This was back in 1955. So this is relatively recently. And Wasson brought some of those mushrooms back to Dr. Albert Hofmann, who had famously synthesized LSD at Sandoz Laboratory in Switzerland back in the 1930s. And Hofmann was able to identify the active ingredient. Here was psilocybin. And so that was in 1958. And so you can see there's some publications about this starting in 1958 when we started to learn what psilocybin was. There was increasing interest, including research done here in the Czech Republic back in that time. Obviously they were working actively with LSD as well. But really there was obviously a very global phenomenon in terms of the war on drugs and criminalization of these substances that made it difficult and kind of taboo to study them for decades. And so it was not really until about the 2000s or the turn of the 21st century that we see this uptick in work. And now, of course, there's a huge amount of interest in both the scientific community, but also the lay public and in popular media. Thankfully, Vivian did a really nice job talking about this earlier, so I don't have to talk too much about it. But when we are doing therapy in these clinical trial settings, we're usually doing some preparation with facilitators. There's a whole sort of supportive process that happens before, during, and after the administration of the drug. And we're often using just 1 to 3 high doses, depending on the protocol. The dosing sessions with psilocybin last roughly 8 hours, and we do try to make it an aesthetically pleasing and comfortable environment. Very often we're taking a non-directive approach, meaning we don't really talk to people or try to elicit a lot of psychotherapeutic content when we're doing this. We just ask them to lie down and to have an experience, an inner experience, and often they're listening to music, and it looks something like this. Now, the state of the science so far has shown these, psilocybin in particular, but also some of these other psychedelics like ayahuasca, are rapid-acting antidepressants. 1 or 2 doses of the drug seem to produce pretty strong antidepressant effects within 24 to 48 hours. Not in everyone, but in many people on average. And these tend to last for weeks after a single session. This seems to have some really intriguing potential in palliative care settings. So when people that are working at the end of life through existential distress and related anxiety and depressive symptoms, this seems to be quite helpful, and that has now been replicated both from research in the 1960s and more recently. And we've seen a lot of really interesting work looking at these drugs as treatments for addictions, which is an area of interest of mine, but I won't talk too much about it today. And this is just to kind of recap some of that data. I like this particular graph because it shows individual subject data, and what you can see is many of them are starting quite high with their depressive symptoms on the left-hand side of the graph, and over time, after they're administered 1 or 2 doses of psilocybin, there's reductions, and on average, they end up lower than where they started, but that's not true for everyone. You can see, obviously, there's people here that are not responding to the treatment. There are also people who have a response initially, but then bounce back into depression. So this is much more complicated than what you often are looking at when you're looking at averages of the groups. And this is, of course, from a very nice paper from Imperial College London in New England Journal of Medicine, where they showed that indeed 2 doses of psilocybin were as effective, if not more so, in treating depressive symptoms than the SSRI citalopram, which is an FDA-approved, EMA-approved medication. Of course, Compass has also done a really nice large study showing, again, there seems to be some dose-dependent effects. So 1 milligram or 10 milligrams of psilocybin don't really seem to do the same thing that 25 milligrams do. Exactly why that's the case, still unclear, but something about pushing the dose to this higher level seems to be a prerequisite for really getting the true antidepressant effect, and I would also say for some of these anti-addictive effects as well. These are some more data from clinical trials in cancer patients, but basically these are very just congruent, showing reductions in anxiety, reductions in depression. But one thing that I think is quite interesting from the early work that was published in the 1960s was specifically work in cancer patients, obviously not looking at trying to treat their cancer nor their psychosocial distress, but in this case, this fellow named Eric Cass was working with pain, cancer-related pain, because often people have quite intractable pain when they're dealing with these illnesses. And his first study, what he found was that a high dose of LSD would create as much of an analgesic effect in these patients as some pretty heavy-duty opioid medications. And as you can see, after the LSD, 9 hours later, they're still having these reductions in pain, whereas after the dosing with the opioid, you're getting a sort of return of that pain. This is really fascinating work that kind of starts to bridge this gap between the psychological and the physiological effects of these drugs. Cass went on to do a really nice large study with 128 patients. Again, this stuff is not talked about very much, but what he found was that on average, these people were showing reductions in their pain overall about 3 weeks after a high dose of LSD. So these are compelling results. And there have been some, researchers nowadays, including these folks here who are mostly at Maastricht, looking at, can these drugs be used for treating pain-related conditions? This is just from a survey of psychedelic users out in the real world, but really just asking people with chronic pain who have used these types of drugs, what's been most effective in terms of reducing some of your pain symptoms. And it looks pretty clear that opioids, falls lower on that continuum than macrodose, high dose of psychedelics. And so, this has also been wrought out in some neurological conditions now. These are all very small studies, so obviously need to be interpreted with caution, but, this is from a group in Denmark, and, what they found is that in adults with cluster headache, which is a severely difficult to treat and painful condition, that there's significant reductions after psilocybin, in this case using low doses of psilocybin. And this has also been seen in other groups at Yale who have been studying other types of headache disorders, including migraine, showing that psilocybin, low-dose psilocybin, can reduce migraine frequency and intensity. Interestingly, and this is of note, that the changes in migraine are not correlated with psychoactive drug effects, which is something that I'm going to come back to here. But again, there's let's see. Sorry, I'm stuck here. Yeah, it's not doing anything.
Joe's presentation? Joe's presentation? Can you exit? Mouse is still there, so it's a crash buttons. Shift to 5, so start from the first
Should
slide.
be working now.
Let's see. There we go. Okay. Yeah, and so as I was saying, these small studies have found that psilocybin can be really potentially useful for treating these neurologic conditions, and it doesn't seem to be correlated, the effectiveness of these drugs for headache, specifically cluster headache and migraine, with the psychoactive effects. So that's, I think it's quite interesting because one of the huge questions in the field, of course, has been, do the subjective effects matter? And this is from a little paper that we had published back in 2014 with a bunch of people who had been in a smoking trial, tobacco smoking, who wanted to quit smoking. We gave them psilocybin. We asked them 6 to 12 months later, what was most memorable about this experience for you? And many people had these types of things to say. This is what their words were, not our words. But there's often these types of very mystical type influences. We're all one, the awareness that all is one. And so the idea that these subjective effects are important seems, to prevail, in the field, and we don't really have an answer. But we have seen correlations in, our tobacco smokers, in our cancer patients with, the depth of the what we call mystical type effects, probably not the best terminology in science, but maybe the feelings of unity that people experience when they're under the influence correlates directly with their reductions in depression, reductions in anxiety afterwards. And of course, we've now seen this replicated in the largest study of psilocybin to date, which is the COMPASS study, where again, feelings of what they call oceanic boundlessness and also emotional breakthrough were correlated with antidepressant effects after treatment. Interestingly, this seems to hold in many different types of situations. So not just in clinical trials. This is from a small paper we just published in naturalistic settings. These are people using psychedelics, including LSD, psilocybin, MDMA, at raves, but also in places like spiritual retreats. And again, even in these types of settings, in naturalistic use, what we're finding is prospectively that what the drug effects are psychoactively are then later correlating with reductions in things like PTSD symptoms. So although the data are not consistent, it seems like, to me, when we're looking at things like psychiatric and mental health conditions, some of these psychoactive drug effects during the drug sessions are very important for opening up some of the insights and catharsis and also facilitating therapeutic benefits. But it seems also that there may be other pathways by which these drugs are working, perhaps that might be amenable to treating things like pain, inflammation, and neurological conditions. We may be able to dissociate these mechanisms. It's still unclear whether you need to have one for the other. And so this is starting to move us towards these questions of understanding how these drugs work. And we've talked a little bit about neuroplasticity today, and I think this work is really interesting because it's not just showing us that these drugs work on the mind and change how we feel, but they're actually working on the structure of the brain. So if you want to call it the body, it's working on the body. Specifically, this paper just came out a couple weeks ago from Alex Kwan and his group, showing that indeed 65 days after one dose of psilocybin, these rats are still showing an increase in new synaptic spines. And so you can see right here, it's really nicely kind of laid out over time that this is somehow related to the drug effects, and apparently the serotonin 2A receptor is necessary for this because this did not happen in the mice that were serotonin 2A knockouts. What's also interesting, though, is that in addition to these long-term structural changes, we're also seeing, this is from a nice study at Yale with EEG, not just like what we had seen earlier from folks like Marek and Jack, who are showing us that the electrical activity is quite different of the brain when you're under the influence. But in this study, this was psilocybin with depression, people with depression, looking at their EEG 2 weeks later found increased theta activity. And that increase in theta activity 2 weeks after psilocybin, which they don't see 2 weeks after placebo, and they don't see 1 day after psilocybin, is again specifically correlated with their reductions in depressive symptoms. So it's changing the way the brain is structured, it's changing the electrical firing patterns of the brain acutely, but also up to 2 weeks later, we're still seeing that the brain is acting differently. And of course, these types of data have also these types of results have also been found using MRI. So there's a lot here to try to unravel in terms of the mechanisms underlying all these different beneficial effects that we're seeing. So this leads me to some of the work that's now starting to happen with what we might consider more classically physiological or physical illnesses. This is from a small study done out of a group in Michigan with patients with fibromyalgia. And I just actually came back from giving a talk last month with Julia Bornemann, who's from Imperial College London, and she's done a little bit of a larger study in the same cohort, people with fibromyalgia. And what both of these studies found, and Julia's study is not published yet, but it will be, is that people who are receiving a couple of doses of psilocybin with psychological support are showing reductions in their pain severity, they're showing improvements in their symptom burden. So I think this is really an interesting, important direction. A small study with patients with Parkinson's disease recently showed that, again, their depression and anxiety is reduced after psilocybin, but so are their motor and non-motor symptoms of Parkinson's, which is something that you wouldn't necessarily be thinking to look for. Similarly, they're having improvements in their cognitive function post-treatment. So finally, I'll just kind of end with this, which is a study that we'll soon publish, I hope, in the next couple of months. But we have done this study in people with post-treatment Lyme disease. So this chronic Lyme disease is a really interesting vector-borne illness. Mostly people get this after they're bitten by ticks that have a certain type of bacteria, and they develop this infection. Most people are successfully treated with antibiotic treatment, but about 15 to 20% continue to have persisting symptoms that can be quite distressing. This includes things like fatigue, pain, depression, sleep disturbance, and cognitive dysfunction. And this is a really nice study that some of my colleagues at Hopkins did looking at PET imaging, basically looking at what you see here is the brains of people with chronic Lyme disease on the right versus matched controls on the left, healthy people. And what you're looking at is actually the binding of these radio tracers to what they call activated microglia. These are glial cells. Usually we think these cells are used to move waste out of the brain. They're inflamed. They're showing markers of inflammation in the brain that you're not seeing in healthy people. And a lot of people think that these types of chronic Lyme and other illnesses are related to ongoing inflammation. And so in this study, we gave 20 patients with chronic Lyme disease 2 doses of psilocybin, 15 milligrams and 25 milligrams, and followed them up for 6 months. I'll just be talking about the data up to about a month afterwards. About half of these people were women. They were on average 44 years of age, and their mean illness since their time of Lyme infection was 6 years. And what we were looking at was this general symptom questionnaire that looks at neuropsychiatric pain, fatigue, and neurologic symptoms. And what we found was that on average, there's a significant reduction from baseline to post-treatment that lasts up to 1 month after the last dose of psilocybin. What we found was that Beck Depression Inventory scores showing their depressive symptoms are significantly reduced after treatment. Their McGill Pain Inventory scores, so this is moving more towards those physical symptoms, is showing significant reductions on average, again lasting 1 month post-treatment. Pittsburgh Sleep Quality Index, looking at their sleep disturbances, insomnia, are showing significant reduction post-treatment. And fatigue severity scale also showing significant reductions post-treatment up to a month after the last dose of psilocybin. This is sent to me by one of the patients in the study, just from her Apple Watch. That watch just flagged this activity as unusual and sent her a message automatically. She sent it to me. On average, her steps before the treatment was about 4,000 steps per day, 3,500, I should say. And after she had received her first dose of psilocybin, her step count doubled on average. And so this is obviously N of 1, anecdotal, but this is the type of thing that when you're talking about fatigue severity reduction, it is very congruent with that. And finally, just to wrap up here, this is, I think, probably the most important. We asked the people to rate their quality of life with this question, considering all parts of my life, physical, emotional, social, spiritual, and financial. Over the past 2 days, my quality of life has been 0 to 10, very bad to excellent. And that has shown significant improvements all the way up to 3 months post-treatment. And that's something that seems like a really important thing to highlight. So these preliminary data are very promising. They should be published this summer. We're going to do a larger randomized controlled trial with neuroimaging to follow up. But the conclusion here is, there's growing evidence for psychiatric benefits of these drugs, but it also begs the question now, the more that we learn, can they be used to treat other conditions, including things like Alzheimer's, fibromyalgia, Parkinson's, phantom limb pain, and so on. I do think it will be a lot of new and interesting questions to understand how these drugs work, what types of dosing regimens, what the mechanisms are, and how all these other compounds I list at the bottom may be useful in those types of conditions as well. So we have a lot of work to do. And I'll stop there. I'll leave my email there in case there's questions that we can't get to now. But thank you very much for your time.
I think we have time for a few questions, and then we will wrap up. And I'll actually jump on the first one. These people who you've dosed with Lyme disease, who you've dosed with psilocybin, who have Lyme disease, Hopefully you didn't do that. Have they all been hallucinogen naive? So have all these people had prior experiences with psychedelics?
Most of them had not. I actually have the exact number on there somewhere. So let's see here. So 16 of those people had never taken a psychedelic before, and 4 of them had. I don't think, I believe as an exclusion, if they had any in the last year, they couldn't be in the study. So, yeah, basically these people had very limited experience. And I would say also they're very desperate for treatment because there are no treatments, I should have said, for this chronic Lyme disease. And so it's a difficult to treat condition. Often doctors kind of think that they're malingering or making this up, which makes it even more complicated and frustrating. So,
all right, thanks.
Mm-hmm.
Yes. So you said the pain reduction is unrelated to strength of subjective effects?
At least in a couple of small studies that we've seen, that were done by Emanuelle Schindler at Yale. She has done what many of us have done to try to correlate the subjective drug effects on the day of the session with the treatment outcomes later. In her migraine patients, in her cluster headache patients, they're using lower doses, like 10 milligrams. It seems to be effective, and there's no correlation with the intensity of drug effects and between that and the way that they have reductions in their headaches later. So,
okay, so they had 10 milligrams and the stronger dose, and there was no difference in pain.
So they don't use a stronger dose for treating migraine. They use actually these low doses for headache conditions, and that seems to be good enough. So, and I don't think, and actually we know that it's not good enough for treating depression from the COMPASS study. So,
thank you.
Hi, thank you for the all information. I don't know if this is a fair question actually, but I'm going to do it anyways. I will consider you working Johns Hopkins as a main insight, like let's call it like that. And every time that I'm in this conference, I see more and more data and more like articles and investigations. And I will say that we have enough data and enough information and use of these compounds to actually move forward some approvals or regulations around this. And why I'm asking this to you specifically, because of course many things are coming from the US and the FDA approving those therapeutical treatments, or it's kind of the best line for the other people like South America or even Europe to start doing things as well. So taking back to the maybe you are the man inside that we can have here, how do you see that those things are progressing, or all this information, all these clinical trials or articles all these studies that have been doing, how they are contributing to move forward those things that we see that, for example, last year with MDMA that was about, everybody was like waiting for it, it just stopped.
So it's a great question. I mean, my general sense is that these drugs will probably, and when I say these drugs, I should clarify, I mean psilocybin and MDMA will probably become legally approved treatments by FDA and probably EMA in the next 3 to 5 years. And that's something that many people have been working on for a very long time. It was disappointing, I think, that FDA did not decide to approve MDMA last year. There's a lot of different reasons why that probably came to pass. But thankfully, at least at this point, there's a lot of people that are working on these big phase 3 trials that basically will pass the muster, the bar to show that it's safe and effective, psilocybin for depression or MDMA for PTSD. So I think that those are getting there. And it's just the problem is, to get to this point of FDA approval, they have to do what a pharmaceutical company would have to do to show effectiveness, and it's expensive and it's time consuming. I wrote a paper earlier this year with one of my postdocs who is from Canada, and in Canada they have a special access program where people are able to use these drugs even though they're not approved if they have a life-threatening illness. And so people with like severe cancer are now able to sign up and go use it with government approval. And what we were arguing was that other places like the US and perhaps elsewhere should be thinking about these types of allowances where if people are given the risk-benefit profile and have a serious condition and there's some data to suggest it may be helpful, that they may be able to go get this without it being approved medicine. I think that would help. We'll see the government work slowly, and particularly now things are quite chaotic in the U.S., unfortunately.
Hey, thanks for your research. I am very curious about the role of psychedelics within rehabilitation, whether that's from brain damage or rehabilitating to be able to walk, for example. And I'm curious if you have any opinions or if you know of anyone doing research around the augmentation, the acceleration of rehabilitation with the occasional doses of psychedelics in that rehabilitation process. And if you have anything to say on that.
Yeah, Gould Dolan, who was at Hopkins, she's now at Berkeley, but they're still doing that study now at Hopkins. These are with people who are post-stroke, and they're in a rehabilitation. And so the idea would be that perhaps this neuroplasticity inducing effect may help those people rehabilitate faster than without the drug. So they're testing it there. Obviously, Nolan Williams did a nice study with ibogaine and TBI patients. I'm developing a TBI study now. So I think, looking at people who are dealing with, again, some of these, what you would consider physical traumas that could potentially then go on to benefit from these drugs is really interesting. So.
Yes, thank you for your talk. It was super interesting. I asked myself, is there an explanation for this pain-reducing effect of LSD already, or did I just miss it?
So, in many ways, we really don't know how these drugs work. We have ideas about what they're doing. In terms of how the pain-reducing effects work, it's going to be purely speculative. There's potentially some modulation of top-down pathways, which we know, for instance, the way that our brain is processing the pain information that's coming up to it from the different, nerves and different regions could be modulated either, through conscious or unconscious processes. So it's possible that that's part of what's happening. Again, I didn't get to talk about this too much, but there's also these anti-inflammatory effects that occur when we're administering psilocybin and other psychedelics in animal models, and potentially in humans. We've seen some changes in that type of signaling. So it's probably really complicated. We don't know the answer, but we're trying to understand because, again, back in 1964, they already knew that this could potentially be helpful, but obviously there hasn't been that much more research since then. So.
Thank you for that. And one more question. Yeah, this way it's quick. So.
Just because you mentioned Nolan Williams, I was wondering if you have thoughts about potential applications of ibogaine for neurodegenerative illness, like, for example, Parkinson's disease.
I think it would be really fascinating to study. I'm doing a small study now of psilocybin in patients with Alzheimer's disease, and it's been difficult to recruit patients, I think because of generational differences and views around these substances. But also, I've been using macrodoses because I think that tends to be most effective. However, this is a more frail, population, and so I think giving a high dose of a drug like that would be difficult. Of ibogaine, for instance, which may have cardiotoxicity, but it's very possible that even low doses could have some benefits. So I hope at some point it'll be easier for us to do more work where we can study these questions more quickly. But as it is right now, it takes at least a year, usually 2 years, just to get the approvals to start a new study. So it's just a very time-consuming and laborious process. But it's a great question.
Any last questions before we wrap up? That was a really interesting talk and really good questions. Another round of applause for Albert. Thank you so much.